Good afternoon, everyone. Welcome to our Thursday afternoon educational webinar with the Cholangiocarcinoma Foundation. I'm Melinda Bikini, Director of Advocacy with the Cholangiocarcinoma Foundation. I'm almost a 12-year survivor of stage 4 intrahepatic cholangiocarcinoma. And I'm really excited today to welcome Dr. Cecilia Monge from the National Cancer Institute. And I'm going to let her do a little more of an introduction herself. And as always, we will have questions and answers throughout this webinar, so feel free to put any questions in the chat and I will relay them to Dr. Monge. All yours. Thank you.
Good afternoon, everyone. Welcome and thank you for joining. So a little bit of an introduction. My name is Cecilia Monge. I am a medical oncologist and I am one of the investigators at the National Cancer Institute at NIH with the gastrointestinal malignancies branch. Biliary tract cancers is one of the cancers that we do a lot of research on, and we're very interested in moving this area of oncology forward. Today I'm here to tell you a little bit about a new protocol that we opened approximately 4 months ago and we're very excited about. So this is a protocol that includes combined treatment with immunotherapy, so Durvalumab and Bevacizumab, and I will go into what those are in a second. With Bevacizumab, which is a third drug, in patients with biliary tract carcinoma. This protocol also includes patients with liver cancer, and those with liver cancer also undergo an interventional radiology procedure, which I know many of you are familiar with, called TACE. The cohort with biliary tract cancer is with the 3 drugs only. So we're very excited about this protocol because although there's been some response with immunotherapy in biliary tract cancers, specifically we see more responses in tumors that are PD-L1 positive, or to say it in a more straightforward fashion, that have certain characteristics that really very few patients have. But from animal studies that we've been conducting in our lab and from early clinical studies that have been published recently in other malignancies, we've seen that combining immunotherapy with other agents may be an important step forward in biliary tract cancer. So let me go more into that. So the immunotherapy part of this protocol, as I mentioned, is the Durvalumab and the Tremelimumab. So Durvalumab is a PD-L1 inhibitor, Tremelimumab is a CTLA-4 inhibitor, and those are sometimes are a bit of complicated terms, but basically what those 2 drugs are doing is that they're trying to get the immune system of the person with the biliary tract cancer to take off the brakes that the cancer has put on the immune system so that the patient's own immune system can target the tumor and get rid of the malignant cells. That's the immunotherapy part of things. But as I mentioned, immunotherapy alone in biliary tract cancer, we've really seen only works in a very small amount of patients with certain characteristics. So what's been interesting is that when we've added Bevacizumab, so talking about a little bit about Bevacizumab is, so basically Bevacizumab targets angiogenesis. So angiogenesis, that word, what it means is basically the formation of new vessels. And in the case of tumors, basically the formation of capillaries, which are really small vessels. The formation of capillaries and vessels in general in tumors, and specifically in biliary tract cancer, is very important because the tumor depends on that for its own growth and also for it to develop metastasis. And as we all know, the prognosis of the patient is very much dependent on both of those things, the size of the tumor and the metastatic burden the patient has. So basically what Bevacizumab does is that it targets a certain factor called VEGF, and targeting that factor, it makes it harder or impossible for the tumor to develop further vessels, so to grow further and to develop metastasis. So what we've seen in the lab is, with our animal models, is that when we combine immunotherapy with Bevacizumab, so we're helping the immune system in from two different angles. One is taking the brakes away, and the other one is not letting the malignant cells have the capacity to develop further vessels for the tumor to further grow, then we've seen an important decrease in the tumors in our animal models. This, in combination, what we've seen in the clinic with other cancers, so specifically melanoma is using this combination right now, and renal cell carcinoma, and a little bit closer to home for patients with biliary tract cancer. As we know right now, the first line standard of care, which is FDA approved, is actually a combination of one immunotherapy drug and one drug, which is the same drug, actually, Bevacizumab, that targets the vessels in liver cancer. And although biliary tract cancer is different from liver cancer, it sort of puts more emphasis into the logics of this combination, that in hand with what we've seen in our animal models. So, as I mentioned, this study started recently, 4 months ago. So we're starting to accrue patients, and it's very important. I need to clearly say that we don't know if this is going to work or not because we are very early on. But as many of you know and have had experience with biliary tract cancer, unfortunately, sometimes the progression is fast, and we are really thrilled that what we've seen so far is so encouraging. So although we can't say that it's going to work, having quite a bit of experience doing research in biliary tract cancer, we're really excited with the results we're getting within our first patient. So that's something that has us all very excited here in Bethesda. I'm going to share the next slide with you, which shows the study design, because this is something that I think is important. I think that the most valuable thing that all of us have really is our time. And so it's important to know what the study design looks like for this protocol. So the protocol is based on a study design that's basically 3-week cycles. So that's why you can see there it says day 1, 22, 43, and then going forward. The 3 drugs are given only on cycle 1, day 1. And then after that, only 2 drugs are given, Durvalumab and Bevacizumab. So the first time that the patient comes to the NCI in Bethesda, they usually stay 2 days, and that's because there's a biopsy procedure that's done with cycle 1, day 1. But then after that, they really come back to see us every 3 weeks. So it's not very time intense. And because of the type of drugs that we're using, we've used these drugs in other malignancies here at the NCI. And although adverse events, of course, are always a possibility within studies and with study drugs and with immunotherapy, our experience has been that the side effects are very manageable. And when we compare it to other protocols that we have that included chemotherapy, for example, these studies are more tolerable for sure. The patients get a CT scans every 9 weeks, and that's basically looking for the response that the tumors are having to the therapy. Right now, the idea is to accrue a small group of patients to see if the results are what we expect. So we're accruing between 10 and 12 patients, but there's been a lot of interest in the study. So right now we've already accrued almost 5. So we're thinking of expanding that to 20. So I think there should be enough. The reason we're expanding is because of the encouraging results that we've seen so far, specifically because our patients are heavily pretreated, and we know how aggressive, of course, biliary tract cancer is. Patients must be, of course, locally advanced and not candidates for a surgical resection, because, of course, that is always the first choice of therapy when it is on the table. And we are accruing patients that have already received first-line chemotherapy, and in most cases, that would be gemcitabine and cisplatin, although some of our patients are coming in actually with a combination of gemcitabine and cisplatin and nab-paclitaxel, because there's a recent phase 3 study in place that seems to be having good results. So we've had some patients that have been treated with that prior to accruing. I think that's what I have right now for this study, and I'm happy to take any questions and comments. And thank you again just for joining us.
Yeah, so I'm going to ask a few questions. I guess I would want to know a little bit more about the inclusion and exclusion criteria. Can they not have had any other previous immunotherapy treatments?
Right, so that's an excellent question. Thank you for bringing that up. So in the inclusion criteria, yes, right now we are excluding patients that have had prior immunotherapy treatment. So it's usually the patients that we're accruing have gone through usually first line treatment, which would be chemotherapy, but have not received immunotherapy. All patients must be 18 years of age or older. There must be a histopathological diagnosis consistent with biliary tract cancer, cholangiocarcinoma. And then there are some minimum requirements as far as organ function, and that's pretty much across the board for most protocols in oncology, but they do include liver function tests that are not necessarily normal, but usually less than 5 times the upper limit of normal is what's accepted. And that's the case for this protocol as well. Then a good bone marrow function. So patients that are not severely anemic or have a low platelets, specifically for this trial, we look at the platelet count and we would like the platelets to be over 60,000, just because, as I mentioned, the Bevacizumab does work basically in making the tumor not able to further develop vessels, but because of that, there is some low risk of bleeding, and that's why we really like to see patients come on this protocol with platelets more than 60,000. As with other protocols, performance status is very important. And so performance status is what a patient is able to do on a daily basis. So we've seen in oncology that patients that spend 50% or more of their time either in bed or on the couch because of the fatigue that the cancer is causing, usually these patients usually don't do well with any treatment on protocol. And one of our main goals when we treat cancer is to get the cancer under control, but also for the patient to have a good quality of life. So if a patient is already having problems with quality of life, we don't encourage the patient to enroll in these protocols because the last thing we want to do is harm.
Okay. I hope I didn't miss it through your earlier or first description about the previous immunotherapy, but what about autoimmune diseases? Anybody on steroids or anybody who's had a transplant that has had a recurrence, are they eligible?
So that's also an excellent question, and thank you for bringing that up. Because we are targeting the immune system, we've seen that patients that are on steroids that are an equivalent of 10 milligrams of prednisone per day or higher don't do well on this protocol, so their cancer doesn't respond. So we exclude patients and help them look for other protocols that may include them. But patients that are taking 10 milligrams or more of prednisone per day this protocol would not be an ideal option. Patients that have autoimmune diseases, if they are diseases that are systemic, like lupus or rheumatoid arthritis, those are also exclusion criteria because the immunotherapy that's given on protocol may make these diseases worse. And patients that have had a transplant in the last 5 years are excluded as well because they're already taking immunosuppressive drugs. So the immunotherapy would not be the best option.
Okay. All right. We have a few questions that came in. Can I get details, drug names, application process for the study, etc.?
So the first part of enrolling on this protocol is for us here at NCI to take a look at the patient's records. So we go through the last medical oncology notes, the labs, and then the patients send us the imaging, usually on CDs, or they upload it directly to our computer system. And although this sounds like a long process, it's actually something that we're able to do in 2 or 3 days. And then once we look at all this information, and we think that the patient may benefit from the study, then we reach out via phone, and then we schedule a screening visit in person.
Okay.
And this
So
is something that takes up a week usually. So we move fast because we understand that biliary tract cancer is a malignancy where we all want to move fast.
Okay, so they could reach out to you, Cecilia, or is there a research coordinator?
Yeah, so there is a research coordinator, but the easiest way is to reach out to me, and then I'll link everybody in that needs to be included so that we can get the records in place, we can review everything and get them on our clinic schedule as soon as possible. So yes, please feel free to share my email, and please feel free to reach out to me directly.
Okay, I'll see if I can get Rick to post your email in the chat so people have it. Okay, so generally biliary cancer does not respond well to immune therapy unless they have MSI high or PD-1 expression or such. Is there evidence that the Durva-Bev-Trem combination might be different?
Yes, so that's an excellent question, and thank you for bringing that up. So that was exactly the sort of the question that we had. We said, well, because the patients that do respond to immunotherapy that have biliary tract cancer do so well, that we're trying to figure out with our animal models how we can make patients that are not PD-L1 positive, don't have the characteristics that are usually required for a good response to immunotherapy, how can we get those patients to respond? And what's been very interesting for us is that when we add the Bevacizumab, when we add this anti-VEGF inhibitor to the mix in our animal models, there is a response in the tumor. And every malignancy is different, but the data that's coming out from renal cell carcinoma that's using the same combination and they're responding well regardless of the PD-L1 status, it's promising, as well as the data that we have from liver cancer. These are very different cancers. So really what we are most excited about is our own animal data here at NCI, what we've seen in our lab. And as I mentioned, the responses we've seen in these first few patients that are not anti-PD-L1 positive and are responding to the treatment. But of course, this is like every study. This is the foundation is in science. This foundation is in our animal studies, but we don't know if it's going to work clinically or not yet.
Okay. Are patients with a diagnosis of PSC eligible for this study if they have good liver function?
Yes, patients with primary sclerosing cholangitis are eligible for this study.
Wonderful. Okay, so what defines first line? This person had a resection, then Xeloda. So does that exclude her, or would that be considered first line therapy?
So it seems like the patient mentioned is in the fortunate group of patients that was a candidate for resection, and then getting Xeloda after the resection is a sort of standard of care for 6 months. So the first step that we would want to take with a specific patient is see if the patient now has systemic disease. So if the patient is with no evidence of disease, then this protocol would not be a good option for them, because this is a protocol for patients with advanced disease with metastatic disease. So let's hope it's not this patient, but it would look more like a patient that went through resection, may have gotten Xeloda, then developed metastatic or advanced disease and was treated with first-line chemotherapy, so Gemcis, or as I mentioned before, Gemcis nab-paclitaxel. Then this would be a good protocol and a good treatment option for that patient.
Right.
So a patient that's been resected and has gotten a capecitabine as adjuvant therapy and has no evidence of disease is not the ideal patient for this protocol.
Right. But if she were to, or if they were to have a recurrence, yes, they would still have to do Gemcis and progress on Gemcis before they could enter into the trial.
Well, I'm happy you bring that up. So the protocol is written for patients that have progressed through chemotherapy, through gemcitabine and cisplatin. But not specifically on this protocol yet, because all the patients that we've gotten have had systemic chemotherapy, but in our other protocols, and the way the protocol is written and presented to both our IRB here at NIH and the FDA is if the patient has refused first-line systemic chemotherapy, the patient is also eligible. So I will give you an example. So this is another protocol, but a patient I saw yesterday who, because of quality of life reasons, did not want chemotherapy. So absolutely did not want chemotherapy, understanding that that was the option that's FDA approved and that we know works. If a patient makes this decision with all the knowledge that a patient needs to have to make this decision, we accept those patients on trial as well. So if the patient has gotten systemic chemotherapy, or if they refuse to get systemic chemotherapy, and that may be because they have some neuropathy from some other etiology, or they've had chemotherapy before and developed neuropathy, and they just really don't want to have more chemotherapy, or a patient that just feels strongly against chemotherapy altogether, those patients are eligible for this protocol.
Very happy to hear that. I like that.
Yes.
Written in like that.
We strongly believe that as long as our patients have the knowledge of what the data says, of what percentage of patients will respond to the chemotherapy that they're choosing not to get, then we'll work with the patient and with the goals that the patient has for their life.
I love that. Okay. So what is the official name of the protocol?
So the official name of the protocol is the one that's right there. So it's a phase 2 study of combined Tremelimumab, Durvalumab, and Bevacizumab. And this is the official name, and that's why the hepatocellular carcinoma patients are included there too. What's more important on this slide is the number that's right there. That's NCT 03937830, because that's the number with which everyone joining us today can look up on the internet further details. But of course, please feel free to reach out to me directly as well, because I can always give you a bit more information and answer specific questions. I'm happy to answer emails, and I'm also happy to jump on a phone call with a patient or family member for a few minutes.
Thank you. And I believe it's posted on the cholangiocarcinoma website as well. Maybe we can get that link too. Okay, so for patients on the West Coast, is there an option to get drug treatment from local oncology center to avoid travel during COVID?
That's a really good question, and something that we've been trying to work around. But for this specific protocol, and in the next 4 or 5 months, that probably won't be possible, unfortunately.
Okay, but I do want to mention that I don't think you did mention is that if they enter into this trial, because it's a federally funded facility, the cost of their travel is covered, correct?
Yes. So sometimes the first travel for the screening visit, we're not able to cover because the patient has not enrolled on the protocol yet. So that's basically one ticket, or 2 if they come with a family member. But after that, all their travel is reimbursed, and we also help here with a hotel and meals as well. So this is through federal support that we have, that we're able to do this for our patients because it's here at NIH. We don't charge, we don't take any insurances, and we really do anything that we can to make it possible for a patient that's a good candidate and that may benefit from this to take part in the trial.
Okay. So what if the patient is now in FOLFOX for recurring tumor? I'm assuming that would be the same as if they progressed on FOLFOX, that would still count. They could still pursue it, or I'll let you clarify that.
Absolutely, yes. So FOLFOX is sometimes used in biliary tract cancer, and it's actually right now is what's considered a very important second line possibility when using chemotherapy. So many times patients receive GemCis or gemcitabine paclitaxel and then receive FOLFOX. patients that have progressed through either those 2 lines of systemic chemotherapy, or if for some reason or the primary oncologist decided that FOLFOX was the best first-line option for the patient, and the patient has progressed through that, that would be an ideal candidate for this protocol.
Okay. And I think we answered this question. How do we get the information to get into the trial? I think they put Dr. Monge's email address in the chat, so you could email her and she will help you. Feel free to email me and I'll get you the link and connect you to Dr. Monge as well. How is COVID affecting your trials? Do you insist that patients be vaccinated?
So that's a very interesting question. In the worst part of the pandemic, it was very difficult because it was a big risk for our patients to get on a plane to get treated here. So that was a very personal decision that they made. But yes, all of our patients decided to take that risk and continue their treatments with us. What did decrease was accrual, because I think that it makes sense that if you're on a protocol and things are working for you, then you may want to take that risk of flying. If you're going to start on a protocol that you don't know is going to work or not, then the risk and benefit may change. So accrual did decrease for some months before there was vaccination because of that reason. But ever since, I would say, February or March, our accrual is now as high as pre-COVID time as well. We do not use the COVID vaccine as an inclusion or exclusion criteria. So whatever preference the patient has, that's fine.
Okay. Can you provide more information on the travel requirements, frequency and length?
Mm-hmm. So the first visit to NCI is usually a screening visit, and that visit, if the patient lives far away and will be traveling a long time, and if it's the patient's preference, we can combine that visit with a possible consent visit as well. So that would entail the patient coming to Bethesda for approximately between 2 and 3 days, and that's the longest amount of time that the patient will be in Bethesda with us. After that, the patient comes every 3 weeks, and it depends on where they're flying in from, where they live, but they usually either come just for the day and we arrange flights in the morning and at night, or they may stay overnight, but not because we're treating them for 2 days, just because we're treating them one whole day, and because of logistics and flights, it's easier to fly out the next morning. So the first time that the patient comes, it's between 2 and 3 days. And after that, it's every 3 weeks for approximately, they spend 1 day here in Bethesda.
Okay. And I do not see any other questions. If anyone else has any other questions, be sure to put them in the chat. And then, Dr. Monge, I was just going to ask you if you would maybe comment on one other trial that is opening out at NCI that our patients would qualify for.
Absolutely. So this is a recently open trial. So we're actually screening our first patient. So the trial I just spoke about has been ongoing for 4 months, and we have some really encouraging results, and that's why we were so excited to talk about it. But this other study, we just opened. We're screening, I think, our first 2 or 3 patients this week. And what's very exciting about this trial is that it's for patients that have biliary tract cancer that have a KRAS mutation. So as we know, in biliary tract cancer, there are some mutations that can be targeted, and there's some FDA-approved drugs for those mutations. So those include IDH1 and 2, and TRK, FGFR, and others. But basically, those 3 are the ones that we are always looking for. But this is a very exciting trial because this one is geared for patients with KRAS mutations. And what's exciting about the KRAS mutations is that, different to all the mutations that I just mentioned, which are very rare, and seen in basically a low percentage of patients with biliary tract cancer. It depends which biliary tract cancer as far as anatomical location we look at, but they range anywhere from probably 5 to 20%. With KRAS mutations, approximately 40% of patients that have biliary tract cancer have a KRAS mutation. So this is very exciting for us to be able to offer these patients that have a mutation that's currently not targetable a possible treatment option. So the official name of the study is a phase 2 study of the combination of trametinib. So trametinib is a kind of drug that we called a MEK inhibitor, and I'll talk about that in a second. And the second drug is hydroxychloroquine, which is an autophagy inhibitor, and I'll talk about that as well. And basically, it's in patients with KRAS mutations and biliary tract cancer. So I'm going to go ahead and just say the NCT number in case anybody wants to Google it. But of course, you can also contact me directly for this study, but it's NCT 04566133. So what we're trying to do with this study is basically we've seen that patients that have KRAS mutant biliary tract cancers are very dependent on a pathway in the immune system that includes basically MEK1 and MEK2. So as I mentioned, trametinib is a MEK inhibitor. So what we're trying to do is sort of block that pathway and do that in combination with an agent that got a lot of press recently for other reasons, which is hydroxychloroquine. We heard a little bit about hydroxychloroquine at some point in the COVID pandemic. But hydroxychloroquine, what it does is that it helps the immune system as well, just cause apoptosis of any cells that are not considered as self. So this can be viruses, bacteria, or malignant cells, which is how we're using it in this combination. So we've had some encouraging results in our animal studies, and then trametinib has also been approved by the FDA for melanoma. And the reason I say this is that sometimes there are some studies, and we of course have a lot of these studies in which it's the first time the drug is being used in humans. So they're called first in human studies. And they're very exciting from a scientific perspective, but also there's a high risk for toxicity because they haven't been given to humans before. So one of the things I specifically like about this study, apart from the fact that it's for KRAS mutated tumors, is that trametinib is a drug that we know well. And we know the toxicities it has, it's very tolerable. And then hydroxychloroquine, although as I mentioned, we heard it with the COVID pandemic, really hydroxychloroquine has been used for many, many years in the rheumatology part of things. So with patients that have some autoimmune diseases and chronic arthritic processes as well. So what I like about this combination is that although it's the first time that the combination is used in biliary tract cancer, we do know very well the toxicities of both drugs, and we don't expect any specific or special toxicities, which is sometimes a worry that we have when we're doing protocols in which we're using an agent for the first time in human beings.
Okay, so could you run through just maybe a few of the inclusion/exclusion criteria on this trial as well?
Mm-hmm. So the inclusion criteria for this trial are as well. So it's patients that are 18 years of age or older that have advanced or metastatic biliary tract cancer that is not amenable to a surgical resection and that have progressed or refused a first-line systemic chemotherapy. Patients for this trial, if they've received immunotherapy for some reason, that's not an exclusion criteria. They must have a histopathologically confirmed cholangiocarcinoma and organ function. So a bit of what I mentioned before: liver function tests, kidney function, and bone marrow function. That's basically that will tolerate the treatment. So again, patients with severe anemia, would not qualify, or with very low platelets. Patients that are taking steroids, like the other protocol, 10 milligrams or more per day are excluded, as well as patients with autoimmune diseases. Patients that have metastasis to the brain are also excluded in this protocol, just because it's the first time that it's being used in biliary tract cancers, and these patients may progress a bit faster. I think that those are the more important inclusion and exclusion criteria that I can think of right now.
Okay. And what does a treatment plan look like for this, like travel, and how would it roll out?
Mm-hmm. So the treatment for this is a little bit different, and I think it's very interesting because these are both oral drugs. So these drugs are taken every day, and they're taken throughout. So in some protocols, oral drugs are taken for a certain amount of weeks, and then the patient has some days off. In this protocol, these both drugs are taken throughout. And then, different to the protocol I mentioned before, the cycles on this protocol are a little bit longer. So they're 28 days, so almost a month. And because drugs aren't being infused when the patient is seen here in Bethesda, these patients definitely can come and see us and fly in and fly out for those that live far away on the same day, because it's a clinic visit with labs, and if needed every 8 weeks, we do imaging, but the patient doesn't go then to our day hospital to receive infusions.
Okay, wonderful. So there would be less travel, and it's oral, so they would be able to just that would be really easy and convenient for our patients.
Yes.
Okay, I don't know that I can think of any other questions on that one. If you guys have any questions about the KRAS trial, please put them in the chat. How long will these studies go on?
So it depends a lot on how fast we accrue. So every time a protocol opens, there's a certain amount of patients that are planned for accrual to be able to meet the statistical power of the study and be able to conclude if this is something that works and should move forward in research, or if this is something that doesn't work. But from our experience, we approximately know how many patients we accrue usually per month and per year. So I would expect the first study that I mentioned, since we're going to increase the total amount of patients, I think that study should probably be open for 1.5 years. So it's been open for 4 months now. So it should be open for probably 14 more months. And this study with Tremelimumab and KRAS mutated patients, as I mentioned, we're just starting to screen this week. So we're thinking of a time frame between 18 months and 24 months. So between 1.5 years and 2 years for the second study.
Okay. What is the bilirubin level requirement for the KRAS?
For the KRAS, it's less than 1.5, the upper limit of normal.
Okay. And is the KRAS trial only for biliary or for other solid tumors?
Only biliary. Mm-hmm.
Only biliary. Okay. Any other questions from anybody? Please put them in the chat. How can we be part of the trial? Again, Dr. Monge's email is in the chat. You can email her. You can reach out to me and I'll help you get connected as well. What happens after phase 2? Is there a phase 3?
Yes. So when phase 2s are successful and the minimum amount of responses that was statistically calculated to show efficacy happen, then it moves on to a phase 3. So a larger amount of patients. And then from there, it would go to FDA approval.
Okay. Are there any circumstances where the bilirubin level can be dropped for either study? I mean, is that a hard stop for bilirubin levels?
That's a very good question. So it is usually a hard stop, but sometimes we've screened patients that we look at the imaging and we see, that the patient may just benefit from a stent and then the bilirubin decreases. So I would encourage that person that's asking that question to reach out to me, because we're more than happy to take a look at scans and take a look at an individual patient versus me stating right now that it's a hard stop. I think that I'm just really happy to take a look at any patient. If it doesn't work, we can try to look for other things, but I don't want to say in this setting that it's a hard stop, because of the experience that we've had, that there's sometimes ways to bring the bilirubin down, or sometimes it waxes and wanes. So it depends a lot on the level and on the imaging of the patient. So if that person, or there are other people watching that have that question in their mind, I'd much rather just take the time. It won't be much of an effort on your part at all. And I'm happy to take a look at the specific patient.
That's wonderful. So did you say previous immunotherapy is also exclusive in this trial? I think you said it was not. They could have had immunotherapy treatments and still enter into this trial.
That's correct, yes.
Okay. What is kidney function cutoff for both trials?
So we calculate the kidney function with the glomerular filtration rate. So usually it's either that or the creatinine, but sometimes it's easier to just look at the creatinine. So usually we use a creatinine of 1.5 times the upper limit of normal. But again, I would say the same thing with the creatinine than what we just said with the bilirubin. If there's somebody that thinks that they're a good candidate, or has a family member, friend or loved one that they think may benefit from one of these protocols, and they think that the creatinine is going to be the only issue, I would just recommend if they reach out to me, because then we can calculate the glomerular filtration rate, and then we'll go from there.
Okay, so I think the bottom line is reach out no matter what, and go from there. So each patient can be evaluated, and then maybe some of those issues can be addressed.
Yes.
So I have a quick question. So sometimes when our patients don't qualify for a trial based on levels or different circumstances, they can apply for compassionate use or expanded access. Is that ever an opportunity in any of these cases?
So because we are a federally funded research facility, we can only treat patients that are on one of our research protocols. So for that type of use of medications, the patient has to go to just a non-research hospital setting.
Okay, so they could talk to their local or oncologist about those options. Okay,
yes.
Perfect. Any other questions? I'm going to just say that we're going to have both of these trials posted on the cholangiocarcinoma website, and we will share them. Our emails are in the chat, both Dr. Monge and mine. Feel free to reach out, and we're happy to get you connected. I don't see any other questions. So thank you so much for being here to present this, and thank you guys for having these trials available as options for our patients. We're super excited to see more results. Keep us posted.
Absolutely. Thank you for the invitation. It's really an honor to be part of any activity of the Cholangiocarcinoma Foundation, and we're always excited to bring to the patients, family members, and advocates everything we're doing, so that as a team we can all move forward in this disease.
Wonderful. Everyone else have a wonderful week, and thank you again. And give her a call or give her an email, and we'll get you guys connected. Thank you so much. Have a great day.